Hello and welcome to the CHIME Innovation Virtual Summit, AI, Cybersecurity, and the Future of Healthcare. Today we're going to explore transformative AI strategies and delve into emerging technology solutions that promise to transform health and care. We'll discuss why Think Differently is the only AI strategy you need right now. We'll gain some insights from our panelists on the topics of augmented virtual care. We're going to explore some old but also new innovation strategies and discover why customer experience, not digital technology, is pivotal in the new healthcare paradigm. I'm Keith Friedenberg, Executive Vice President, Chief Operating and Innovation Officer at CHIME, and it's my great pleasure to welcome you here today. This virtual innovation summit would not be possible without the amazing support of our program sponsors. Avisure, today modern patient care doesn't stop at the bedside. Avisure's intelligent platform seamlessly blends remote and in-person care with AI-powered virtual sitting and virtual nursing. Thank you to Avisure. Thank you also to Microsoft, who recently announced a new cybersecurity program aimed at supporting hospitals that serve more than 60 million people living in rural America. Cybersecurity attacks continue to disrupt healthcare across the country and pose a direct threat to patient care. Our rural communities are most at risk for these potentially devastating attacks. CHIME applauds the efforts of Microsoft and many other organizations who are taking steps to help our rural healthcare organizations identify and stop those threats before they can cause harm. And finally, thank you to Nordic. Nordic helps healthcare leaders harness the power of technology so the people they care for can thrive. Combining deep clinical experience with extensive technical knowledge, Nordic helps their clients solve the most complex IT challenges, makes technology more useful for care teams, and more beneficial to the business. All right, here's a quick look at the agenda for today's summit. We've got a fantastic program lined up for you, and we're going to kick things off here with a bang in just a few minutes when I introduce our opening keynote speaker. Before we begin, let's cover a few basic housekeeping items. Keep in mind that you can use your attendee link to come in and out of the summit as your schedule allows. Every session today is live, but we are recording the entire program. So if you miss something, you'll have an opportunity to catch up later. We'll send a link out for all the recorded sessions to all of our registered attendees at the end of the program. But again, feel free to drop in and out as your schedule allows you to participate today. Please note also that we're going to be taking very short 5-minute breaks in between each of the live sessions today. So feel free to use that time, stretch, hydrate, catch up on messages, whatever you need to do before that next live session begins. And finally, unfortunately, due to time constraints, there's no formal Q&A for today's summit. However, you can use a Q&A function on Zoom to actually send us a question. And if we have a minute or two at the end of the session, we'll try and pose that to our speakers, our panelists today. If not, we'll circle back with you following the summit, and we'll also share contact information for all of our speakers today if you want to follow up with them at the conclusion of the program. Okay, we've got the housekeeping items out of the way. And it's my absolute pleasure to introduce our opening keynote speaker to get things kicked off. Aaron Miri is no stranger to thinking differently or AI. He's a healthcare leader and a CHIME board member, but Aaron's also been pushing the envelope on what's possible for years. He's an early adopter to embrace and explore transformative power of AI in healthcare to enhance healthcare operations, reduce clinician burden, and improve patient care and deliver better outcomes. His thought-provoking keynote session, I think, will inspire you to rethink your approach to technology and healthcare transformation. I'm absolutely thrilled to welcome our opening keynote speaker, Aaron Miri, Senior Vice President and Chief Digital and Information Officer at Baptist Health in Jacksonville, Florida. Aaron, thanks for joining us today and kicking off the summit. We're excited to have you here.
Thanks so much, Keith. Appreciate it. And thanks for all of you for listening today and for all the speakers to come today and talk to you about AI and some of the things going on with AI. And so to set the stage, exactly as Keith said, what we have found here at Baptist and what has worked at numerous health systems, you see every day the massive trade regs highlighting work that's going on, is people thinking different, looking at problems and trying to dissect them in different ways. And it comes down to the old adage of process, then technology, people, then technology. So when you start looking at that and start thinking about how do I actually get that secret sauce to make things work, it always comes down to those basic tenets, your processes and your people, then the tech. So today I'm going to walk you through a couple of examples of things that we have done here at Baptist that really took us thinking differently to solve the problem. Could we have done it with traditional tooling? Could we have done it maybe with other technology? Perhaps. But at the end of the day, we had to solve with the why, answer the why, define the why, solve for those processes first, and then implement the tooling. And so we're going to walk through the challenges that we were facing, how we went about solving it, and what did we actually net result. I'm a big fan of talking about stories, things that have happened, things that either worked well or blew up in our face. That's okay too. But really sharing that back with you so you can take those material items home and learn from them and grow from them. And I'll say it up front and I'll say it at the very end of this discussion. I am always accessible. I am always happy to do follow-ups and detailed conversations. I'm always willing to share my team with you all so that you can learn and go about the journey the same way. Let's get started though. Next slide. All right. So thinking differently, right? I always tell this to my team, what worked before won't work now. And why is this important? Because when you think about legacy technology of the way CIOs have grown up in the community, it really started with those early entrails of get electronic health records in there, get things digitized, do this fancy thing called PACS systems and digital imaging. It really wasn't about optimization of workflow or whatever else. So if you think legacy, right, you would think, oh, I'm just going to buy this tool off the shelf, slam it in, the problem is solved. That's not how it works. So what worked before won't work now. Secondly, we have to be comfortable this day and age asking questions and thinking differently. Now, that's an old adage that we've all said for many years, but let's be honest. In healthcare, we're very comfortable with repetition, and we've always done it this way. Sometimes change can be a Herculean effort. But you have to have the courage and conviction to ask those questions and make sure that everybody in the room together is partnering and asking the why and really working to make things happen. Next slide. So the first challenge we're going to talk about in really looking at is really leveraging machine learning and predictive analytics for improved utilization in our operating rooms, right, in infusion center. This is a very common problem that we all have, which is we don't want schedules for the OR that go unused and blocks going unused. We don't want patients to be waiting in the waiting room going, gosh, when am I going to get in for XYZ procedure? And if you need infusion, for goodness sake, we want to make sure that you're getting that as soon as possible and maximizing the resources we have. So the first case study is all about, call it intelligent hospital operations, right? Which takes a multidisciplinary group working together. The second thing we're going to talk to is something very sad, but very near and dear to my heart in terms of how I feel about this, which is that we have to do more when it comes to leveraging AI to fight this terrible plague of human trafficking. I'm going to walk you through what was going on here at Jacksonville, how we solved that, and how we really put emphasis behind making sure we mitigate this problem as best we can and save lives. Next slide. Okay, so rethinking scheduling. This is a multifaceted, everybody has this problem. I don't think there's anybody I've ever talked to that said, oh, we've got a perfect OR schedule, or we've got a perfect infusion chair schedule, or whatever it may be. It doesn't happen. So we were not managing patient flow and facility utilization appropriately. There were ongoing challenges. Obviously, we had a disconnect between what our surgeons expected, what our circulators expected, what our operators expected. Our technology stack wasn't optimized for it. We weren't seeing the data. Things were going idle, so we had rooms that were basically sitting still, which is a terrible situation when it comes to hospital operations. Our providers were just angry and taking their cases other places, especially for our docs that are splitters, right? They were taking cases of other health systems because they couldn't get in, right? We couldn't get somebody in for a hip replacement for weeks, and that's not going to work. Our infusion center wait times were off the charts, leading to major dissatisfaction. And of course, our staff was upset because they were working odd hours trying to catch up and trying to make it right. The one thing I've always seen in a medical center is that your nurses and docs will do anything they possibly can for the patient. That's it. That is the most important thing to them. So if your tech and your processes are getting in the way, guess what? They're going to go around it and it's going to blow everything up because they're going to make sure that patient gets the care they need. So you have to work together. So we work together to put in a predictive analytics solution to really re-examine looking at our people and processes, to integrate with electronic health record, right? And make sure that we are putting robust dashboards and other things out there so people could utilize it, right? At the end of the day, we were looking for actionable data to really allow for continuous improvement. Why is this important? Because a learning health system is constantly evolving. It's constantly iterating. is constantly looking at itself going, what can I do? Predictive algorithms behind the scenes help to basically get you to that next level faster and more cleanly and successfully. So you have to do all of it, from a data cleanliness to a process improvement to people that are aligned in what you're doing to make sure those dashboards and those analytics and those insights and prompts make sense. So what happened with us? Next slide. So objectives, again, we talked about it, right? Utilizing the OR, access, et cetera, et cetera. I don't want to go through all these again, but the reality was the hospital operators and our surgeons were looking for more OR utilization. Fun fact about Jacksonville, Florida, is there's about 150 people a day moving to this region. We've got new rooftops going up, which means demand is through the roof. I can't build hospitals fast enough to keep up with demand, so we have to make sure we are maximizing utilization. So you had new surgeons building practices, surgeons coming in here trying to bring cases in. Then, of course, for the OR, we had surgeons that had block time going unused. It's amazing how generous some procedures may think a case takes. So what does that actually mean? And then we had robots that were going unused, or robots being used for non-robotic procedures, which from a surgical perspective leads to really wonky outcomes and not the type of efficiency and effectiveness you should be looking for. So historical 44% primetime utilizations, and they did not have access to the OR. It was terrible, terrible utilization. Next slide. So what are the results? Right? I think it's important we look at results. We put in our solution in FY21. Well, what was going on in fiscal year 21? This little thing called the pandemic was going on. So not only were we now using our solutions to make sure we're optimizing the OR, remember, a lot of us were, especially someone like Baptist, which has a PSA that goes from basically south of Atlanta to north of Orlando and out towards Tallahassee. We were shutting down hospitals in various zip codes, moving people from one place to another. Florida was open a little bit more than other states during that time, but we had to maximize our ORs, not just because of what I told you historically, but because we were moving people from one place to another. We didn't want to lose that case volume and really fall behind from a financial perspective. And we wanted to make sure people were able to get their cases. So even in FY21, right, then look at the number of increases of a percentage of cases that we had there, right? 47.4 thousand cases, right? Between 2 years later, we're at 50,000. Same number of ORs. We didn't expand our OR capacity right that time. We have recently. But to the degree of it, we were able to do a 6%, over a 6% increase simply because of algorithmic processes and data insights that allowed us to see that. The algorithms we built allowed us to start prompting and nudging folks going, hey, I know you scheduled 6 hours for a TKR, total knee replacement, but you really need 4 hours, on this robot, et cetera, et cetera. Those are the kinds of insights over time with data and analysis that we're able to provide, and then build the algorithms and logic behind the scenes to prompt our surgeons and prompt our OR teams to be able to get in front of that. Look at the next bullet there, right? Almost 460,000 increased case minutes from FY21 to 23. Think about that. That's that many more procedures we can see for the same block utilizations that we had before. So we unlocked 8,500 hours of approved releases, meaning, yes, you can go do this case. Yes, you can do this case. And it increased 11,000 hours of requests through that, right? So access was increased, right? We opened sooner, meaning you're able to get into the ORs faster with your cases. So 23 days sooner. Think of you waiting for 23 days in pain longer because we didn't have this before. And securing days, right? So when the surgeon asked for that OR slot, we were telling him before, you got to wait till next month, man. Sorry. Now we're able to get them in almost real time to when their case was scheduled, right? Depending on preference and location, et cetera. So to the degree of it, from a hospital operations perspective, this is a multifaceted operational journey to get everybody in line using AI and ML behind the scenes, but really about the process and people behind the scenes. We were able to achieve this. Now, I would be remiss and say it is not the tech. And I will tell you again, it's not the technology. It's what went into the technology. That's what's called thinking differently. That's what's saying that what worked before won't work now. That's what's called asking the right questions and then creating an environment that's safe to ask questions. Next slide. Infusion centers. I alluded to this earlier. Right, we had bottlenecks during the midday. Everybody was coming in for infusion chairs at that point, right? We had patient wait times, drug wait times, because they were compounding in the pharmacy or setting up the bags or whatever it may be that were delayed, right? Almost just as bad, if not worse, The staff were not able to take lunch. Now, I don't know about you all, but if I don't at least get like an apple or something during lunch, I get pretty hangry. Imagine when you're seeing dozens and dozens of patients on a panel, or your infusion chairs are backed up and you've got patients that are hangry, you're hangry. That's not going to work, right? So that was a bullet point to allow us to create time space block so that our staff, which were getting burned out, could have their lunch. Very simple request. But you'd be amazed at how often lunch is sacrificed by a caregiver because they're going to put that patient first before themselves. So nurses' objectives, get that 30-minute time for lunch, distributed workload, et cetera, and decrease wait times to less than 15 minutes, right? So we used our historical data to understand capacity. We built templates and using machine learning to give us trend and optimization. We had over 80% adherence to templates when doing scheduling because of this. And then we were able to refine our daily huddles because of this also. So what did this do for us for infusion? Next slide. This is what had happened, right? Look at this, right? We went from 2019, 2020 time to an average wait time of 18 minutes down to 14 minutes, right? Over 40% folks waiting were over 15 minutes down to 35%. And a lot of that's because of chair utilization and types of chairs, particularly our pediatric patients, right? Look at that. Look at on the fourth column there, right? 19 minutes average wait time during peak hours down to 16 minutes. That 3 minutes adds up per patient. Think about that during the course of the day. So we get a 30% decrease in chair wait times and a 20% decrease in drug wait times, all because of this process for infusion chairs. But what does that equate to? Next slide. So overall, when you look at just infusion, right? And from 2018, 2019 timeframe forward for doing this, we estimate just infusion alone, it's been about a $40 million uplift to the health system. Just infusion, just with AI, just with being able to do this and increase patient sat. This is not the soft cost positive knock-on effects of a happier patient leads to better HCAHPS potentially, or leads to better net promoter scores down the line. Put that all aside. I'm talking about cash in the door, which for any of you that are finance background will be, or you report to a CFO or work with a traditional CFO, be like, great, cash is king. This is material, right? AI leads to material outcomes, leads to material processes. Next slide. All right. Told you this is near and dear to my heart because I think it's horrific, the situation of what's happening across this country and across the globe. So if you think about Jacksonville, Florida, where we're located, first of all, we're in Florida, which ranks third for human trafficking cases, which is just abysmal. I moved here to Florida 3 years ago from Texas, and we also had this problem there. But in Florida, it's really, really sad what's going on. Most of the victims come in contact with healthcare. And then our Baptist electronic health record did not have any tools to help us identify victims. So we were having victims present and leave, but all the telltale signs, we were not picking up on them because of the volume of patients and what was going on. So I give full credit to our nursing staff who said, you know what, we're in Jacksonville. Jacksonville is at the intersection of I-95, which runs up the Eastern Corridor, and I-10, which runs from basically Jacksonville all the way to California. And we have one of the largest seaports in the country. We have a very robust airport, and we connect Atlanta to Orlando to Miami. So you imagine how much traffic is going on the roads and how many people pass through. True story, our pediatric emergency department, right? This is at our Baptist South location, were the ones who came up with this. The nurses were fed up with the fact that these victims were coming in and they weren't able to always spot them, because some of these victims have been sadly coached and rehearsed how to not look like or appear the victims of trafficking, right? They have some other ailment in there and they weren't picking up on it intuitively. Could our electronic health record and AI tools help pick that up based upon cues and other types of questions, prompting the nurse to ask the right questions? Next slide. The answer is yes. The clinical leadership team decided to dig into this. This is actually our flow chart on the right-hand side of how this works to suspect. We built a model because there was no model at all on several indicators of human trafficking, and all the patients that present to the emergency department were required completing by a nurse. Also, maybe even an element that's even more sad to this thing was these were pediatric trafficking patients that we're seeing through the door. And not to dismiss adult trafficking, but this is even worse. We were having children present and we couldn't even tell what was happening. So we built this tool, right, with pediatric patients in mind, knowing it's extensible to adults, to say, what can we do? And this is exactly the flow chart of what happened. And I told you before, it's process and people before the tech, right? We had the tech. Could we figure out the process to build this out and do it? Next slide. Yes. So this is an actual screenshot. This is obviously a test patient. So for anybody in compliance, it's test patient. But this is actually what it looks like from our ED narrator screen, right? Yes triggers, basically yes, no's, and indicators across the board. Red flags for the nurse to be able to say, ask this question, ask this question. We're currently at 93% compliance with the tool for our pediatric ED, 84% for adult. We're always learning. This has been live since about Valentine's Day this year. And we've been identifying several potential patients, implementation less than a year ago. The day this went live, which was right before Valentine's Day, we had a couple of people present. They were luckily spotted because we have very sharp nurses, which they're all smart, but very sharp nurses here at Baptist. This tool goes live. The next day at one of our freestanding emergency departments, in walks a 17-year-old girl who was being trafficked. This tool caught her. We were able to recuse her and save her. So if that is not power in itself, that AI, when coupled with the right process and people that support it and anchor it, I don't know what else is. Next slide. All right. So at this point, I will leave you open for some questions. I know we've got about 3 minutes left, Keith, give or take, but I want to anchor this with people and process, then the tech. Go for it, Keith.
Thanks very much, Aaron. We do have a couple of minutes, so if you're willing to maybe answer a couple of questions, I want to go back to the OR utilization use case. You had some really great statistics there in terms of how you were able to increase OR utilization. I want to ask you though, did you go back and actually talk to the surgeons, and did their satisfaction scores go up as well? Were they happier?
They were, and actually interesting you say that. We have our latest physicians engagement scores we got yesterday, and one of those is your happiness with the OR operating rooms. That's everything, materials, supplies, everything, but it's exceptionally more than what it was years ago, and we track that year over year. So the answer is yes. We talk to them one-on-one. We have a good clinical informatics team that rounds with them and talks to them one-on-one as a surgeon. But then also when they're allowed to anonymously, basically blast you with water or give you kudos, they give us kudos. So I take that as a summation of, yes, we are on the right track. I don't think there's anybody that's 100% happy. I don't think that's possible, Keith, to be honest with you. But I do think that we are absolutely on the right track, leveraging tech to enable patient care.
Yeah, that's awesome. On your second use case, and wow, this is a really tough one. Human trafficking is just such a horrible issue, but the fact that you were able to actually get the right people together, right? It wasn't a technology issue, right? But it's about the process, leveraging the technology then to help you spot and identify those red flags. You mentioned an individual whose life you may have saved.
Right.
Have you shared any of what you're doing with other organizations, or you have?
We have, and in fact, I'm really, my team is just phenomenal at this. They've actually presented at our electronic health record user symposium.
Yeah.
We've been sharing stories with folks. I know the hospitals in the area, those CIOs have reached out to me. We've shared with them. For any of you in an area that you know that you have this challenge, reach out. We're happy to give you a copy of the algorithm and the templates and the questionnaires. This, to me, I hope is added as a standard package in the future for electronic health record. This problem is not going away. It's getting worse. And we have the power and the tooling now to use insights to help mitigate this problem.
Yeah, thanks for that. Thanks for sharing the work that you're doing with others and having that willingness to help everybody fight back in this horrible problem. We've got about a minute left here, Aaron. I had the opportunity last week to host one of our CHIME's regional networking events, Michigan Regional Roundup. We talked a lot about AI. We talked a lot about the hype, right, and where AI is sort of in the hype cycle. I know you're quite bullish, and you've shared a couple of use cases here where you've been able to apply, technology to help solve some really difficult problems. But give us an idea. What are you really bullish about in terms of AI's potential in healthcare? And then along the same lines, what are you maybe a little hesitant about?
Yeah, I wish we had an hour to talk about this. So bullish, I am absolutely bullish on every dimension here. I think we have now compute at our fingertips, leveraging the public cloud services, the CSPs out there. We have compute locally with new chip packages that are coming out from NVIDIA and Intel and others that allow graphical processing locally. We have the ability now with the intelligence of our records that are digitized of years of data now to pull upon and have a larger N number statistically so we can actually get better predictive analytics going forward. And we have a willing group of operators and clinicians that understand, I think partly due to the pandemic, the power of technology. So they come up with solutions like the trafficking tool. Bullish, I'm going to go on the policy, or on the negative side, I'm going to go on the policy. right now we've got a couple of things that are brewing. You have the HTI 1 rules that were finalized by the Office of National Coordinator, basically saying that if you build an AI algorithm, you have to be transparent about it. Okay, makes sense to me. The HTI 2 rules proposed are now out there, really about interoperability of that data. The drawback in all this is you saw the Supreme Court recently overturn the Chevron case, which really was about overreach of federal agencies. So there's a question mark looming with the executive order around AI, with the rules that are starting to promulgate out there around AI. What's going to happen if a lawsuit comes up challenging the regulatory environment of AI? Do the algorithms that have been built have to be rebuilt? Or do they have to conform to different standards, which could elongate the ability for healthcare to use those algorithms? So long-winded answer is I'm bullish on everything, Keith. The drawback is we're also having to hurry up and wait, which is typical with the federal government. What's going to happen? And of course, the 2024 election will play into that as well. So more to come on there. But net, we should not hold back the progress of solving problems like human trafficking and others because we're worried about what could happen. We should focus on what we control now, make a difference today. And if tomorrow we got to pivot, then by golly, we pivot, but we keep fixing this problem for the good of mankind.
Absolutely well said, Aaron. Unfortunately, we are out of time, and you're right. We could talk for another hour easily about some of these topics. I want to thank you again for getting us started. That was an inspiring and also challenging message. Be bold, right? Be bold out there.